Good afternoon. My name is Renuka Dapra and today we are going to discuss cranial nerve examination. So as in previous lecture we had discussed first, second, third, fourth and sixth cranial nerve examination, right? So today we start with trigeminal nerve, that is fifth cranial nerve, right? Next. First of all, trigeminal nerve is a mixed type of nerve, motor component as well as sensory component. Motor component, it supplies muscle of face, muscle of mastication, and for sensory supply, it supply half of face. So sensation of pain, touch, cold, hot, motor, movement of masseter and temporal muscle. And there are two reflexes for trigeminal nerve which is controlled by trigeminal nerve. First is corneal reflex and then jaw jerk. Corneal reflex, with the wisp of cotton we need to touch cornea of eye and there will be blinking of eye. So blinking, that is motor response, that is controlled by third cranial nerve, but sensation, afferent fiber carried by trigeminal nerve, so it's a sensory part of trigeminal nerve. Now jaw jerk, same as corneal reflex, the sensory part is carried by afferent fiber carried by trigeminal nerve. So when we tap at the jaw, there will be opening of mouth, so tap over jaw with mouth open, check for slight elevation of mandible. So we need to open slight mouth and then tap over mandible, so it may lead to slight elevation of mandible or closing of mouth, right? So that is afferent fiber carried by trigeminal nerve, motor response, trigeminal nerve. Next, testing, motor open jaw, check for deviation, have patient bite down, palpate masseter and temporal muscle. So these are the muscles which are supplied by trigeminal nerve. Move jaw laterally against resistance to evaluate weakness or paralysis. Now in case of trigeminal nerve injury, if you want to check motor portion of trigeminal nerve, then we need to ask patient to slightly deviate mouth side to side, or we can ask the patient to take some bite. Right? So strength of this muscle of mastication, by checking strength of this muscle we can check motor component. Now sensation, with the wisp of cotton we can check in three areas for trigeminal nerve. First portion, second portion and then third. So for first we need to check on same side forehead, then second maxilla and third mandibular region. Test with patient close eye should be closed. Evaluate pain, temperature and light touch to jaw, cheeks and forehead. These are the three areas which are supplied by trigeminal nerve, sensory part. Observe response and symmetry. So bilateral symmetry should be there when you test the patient. Paresthesia or any severe type of pain that may suggest trigeminal neuralgia. Any type of burning pain, sensory complaint that suggests compression of fifth cranial nerve, and that is abnormal condition, neurological condition known as trigeminal neuralgia. Next. So in this picture very nicely shown how to check trigeminal nerve sensory part. So these are the three portion. If we divide half of face in three area, so that is first area, forehead area, that is supplied by ophthalmic. Three branches of trigeminal nerve: ophthalmic branch, maxillary branch and mandibular branch. Forehead, it supply forehead, then next middle area, maxillary area and then mandibular, that supply your mandibular skin. Next. Now in previous lecture we had discussed abducent nerve already, so we will not give that much time to this now and then proceed to seventh cranial nerve. Next. Okay, seventh cranial nerve, again it's a mixed type of nerve. Why mixed? Because it supplies sensory supply anterior 2/3 of tongue, sensory supply of tongue, and then it also control facial movement, pure facial expression that depend on your seventh cranial nerve. Next, now that is the course of facial nerve. When your facial nerve leaves the pons, then it will enter in stylomastoid foramen, then it leaves stylomastoid foramen and give its terminal branches, right? So it gives 5 terminal branches and supply many muscle of face. Next, Muscle function, control of facial muscle, motor limb of blink and corneal reflex, secretion of salivary and lacrimal glands, sensation of taste, that is anterior 2/3 of tongue. Okay, posterior 1/3 that is supplied by glossopharyngeal nerve, anterior 2/3 supplied by 7th cranial nerve. Next. Now how to check 7th cranial nerve? For that we need to ask patient close your eyes, asymmetrical elevation of corner of mouth and flattening of nasolabial fold. So this one is known as nasolabial fold. Now in case of Bell's palsy or facial palsy, this fold disappear, right, because of facial muscle weakness. In that case, if we want to check motor component, then simply we need to ask the patient to do some facial expression like frowning of eyebrow, closing of eyeball, frowning of nostril, then open your mouth, close your mouth, blow air with the help of cheek muscle, right? These are the various facial expression. Buccinator, to check buccinator we need to ask patient to take more air inside, this way, right? Next, see in this picture it shows asymmetrical drooping of corner of mouth. One side of corner of mouth is dropped on one side. Next, in this slide they have shown different facial expression. Frowning of eyebrow, elevation of eyebrow, that is done by frontalis, that is also supplied by 7th cranial nerve. Close your eyes. When we close our eyes, so there is one muscle which does this action, that is orbicularis oculi. Then puffing of cheek, that is buccinator muscle work, puffing, right? Show your teeth, so that is oris. When we ask the patient to show your teeth like this, so that is orbicularis oris action. Speech difficulty and drooling or difficulty in handling food. If patient is having Bell's palsy, then there is complaint like I am having difficulty with drinking water or with chewing, because of corner of mouth drooling, because of this corner of mouth is dropped on one side, so it may lead to drooling of saliva also sometime. Next, now for sensory part, simply you need to check anterior 2/3 of tongue, right? You need to ask patient close your eyes first and then ask patient to protrude your tongue. In anterior 2/3 of tongue you need to put some tasteful food or anything. So if patient will receive some type of taste, then it suggests facial nerve is working normally. Now in case of lesion of 7th cranial nerve, we'll get two types of palsy. One is Bell's palsy and second one, that is facial palsy. Now Bell's palsy is a pure element lesion and facial palsy is a pure UMN lesion, that is basic difference. Facial palsy always supranuclear lesion and Bell's palsy nuclear lesion or infranuclear lesion, that is known as Bell's palsy. In Bell's palsy, half of face totally paralyzed. In facial palsy, lower 1/4. If we divide face in 4 quadrants, right? So 1/4 of quadrant that is affected in facial palsy. Not half, complete half of face is not affected in facial palsy. Complete half of face affected in Bell's palsy only. Next. Now next one, that is 8th cranial nerve, that is vestibulocochlear nerve. Very important nerve because it carries sensation for balance also and for hearing also, right? Next. Now if we want to check 8th cranial nerve, so there are two parts. One is balance part and second one, that is cochlear part. Cochlear part is responsible for hearing, normal hearing. Now in cochlear part there are two tests. One is Weber test and second one is Rene test. Now how to go for Weber test next? So this is Weber test. In that you need one tuning fork. You need to tap tuning fork on rubber folder and then you need to put tuning fork on vertex, right? That is normal. Now in that you need to put tuning fork on vertex. Normally you will get vibration bilaterally. But in case of affection, if I am having affection with my right side, so I will get lateralization on that affected side. In this picture there is affection with left side, so more vibration I will feel on left side only, right? So that suggests positive Weber test. Now that is conductive deafness. If there is more lateralization of vibration to affected side, so it's a conductive deafness. And in case of sensory neural deafness, there will be lateralization of vibration towards the unaffected side, right? On affected side, patient will not feel any type of vibration, so that shows there is involvement of sensory nerves. So it's a sensory neural deafness. So that is Weber test. Next. Now second part, that is Rinne test for cochlear part examination. In Rinne test, simply you need one tuning fork. You need to put that tuning fork over that stylomastoid foramen, and then you will feel vibration. When vibration go, at that time you need to remove your tuning fork and just put in front of ear. Normally air conduction should be more than bone conduction. Okay. Now in case of affection, what patient will feel? Bone conduction will be more than air conduction. So that suggests some abnormality within 8th cranial nerve. So that is Rinne test. Next. Now tinnitus. Tinnitus, that is because of some lesion with 8th cranial nerve. The meaning of tinnitus, continuous sound. Okay, in case of silent zone, if patient will be in silent zone, still some noise will be there, continuous some tiny sound will be there, that is tinnitus. So tinnitus may be continuous, it can be intermittent, unilateral, it can be bilateral, high pitch, it can be low pitch also. Now when hearing loss is accompanied by tinnitus, there will be conductive deafness, so that is low pitch tinnitus. In case of sensory neural deafness, high pitch tinnitus will be there. Pulsing tinnitus will be there if patient is having vascular problem. Vertigo. Vertigo, simple meaning of vertigo, that is imbalance. Patient will feel some rotatory movement continuously. So that is vertigo. Illusion of rotatory movement due to disturbed orientation of body in space. Cause, disease of labyrinth, vestibular nerve, involvement of central connection of labyrinth and vestibular nerve, that may lead to vertigo. Now in vertigo, patient will sometimes feel nausea, vomiting, continuous nystagmus, imbalance. So these are the characteristics of vertigo. Patient can't able to turn head side to side, jerky movement of neck, especially patient will avoid in case of vertigo. Now 9th cranial nerve, that is glossopharyngeal nerve. Name itself suggests glossopharyngeal nerve. So it supplies your muscle of that laryngeal and pharyngeal muscle and posterior 1/3 of tongue. Again it's a pure mixed nerve. Not pure mixed, but it's a mixed nerve. Whereas your 8th cranial nerve, that is pure sensory nerve. So glossopharyngeal nerve, it's a mixed type of nerve. For sensory portion, it supply posterior 1/3 of tongue, and for motor, it supply laryngeal and pharyngeal muscle. Next. Now vagus nerve. Vagus nerve, again mixed type of nerve, because for motor component it supply glossopharyngeal muscle and laryngeal pharyngeal muscle, plus it also supply internal organ, as well as it carries afferent fiber from internal organ, so it control both afferent and efferent work. Next, that's why it's a mixed type of nerve. Motor parasympathetic fiber to all organ except suprarenal gland, and it also supplies skeletal muscle. Mainly these are the laryngeal and pharyngeal muscle, which is supplied by 9th cranial nerve also and 10th cranial nerve also. Okay, next. Now gag reflex. Normally if we touch our uvula, then there will be some gagging, right? So that is gag reflex. Now in case of 10th cranial nerve palsy, you will get some weakness of palatal muscle, and it may lead to flattening of this palate. This fold will be reduced, and opposite side, on normal side, there will be elevation of palate muscle. So that is gag palsy. We can say it's a palsy of right palsy, right? Reduction of gag reflex. Next. Palatal weakness, it can be unilateral, so minimal symptom. Bilateral, nasal regurgitation, nasal quality of speech, that will be affected. Pharyngeal muscle, unilateral, pharyngeal wall drops on affected side. Bilateral, marked dysphasia. Now, this picture shows normal vocal cord. If we are able to speak, right? So that is because of vocal cord muscle. Now, in case of normal vocal cord, these are the two door, we can say door of vocal cord. Now, if we close our vocal cord, so that will be tightly closed. But in case of pharyngeal, that affection of 10th cranial nerve, if we want to close vocal cord, so vocal cord will be not closed completely, it will remain some open. See, in this picture you can see it will be slightly open, right? So vocal cord will be not closed properly in case of 10th cranial nerve lesion. So vagus nerve lesion, above origin of recurrent and superior laryngeal nerve. Unilateral, if unilateral present, then mild dysphasia, hoarseness of voice, and reduced vocal strength. Bilateral damage, it may lead to weak cough. Next. Now, cranial accessory nerve. Next, it's a pure motor nerve because it supply only two muscles, sternocleidomastoid and trapezius muscle. 11th cranial nerve, pure motor. Next, sternocleidomuscle and trapezius supplied by this cranial nerve. Unilateral lesion is commonly common, and in that case it may lead to weakness of sternocleidomastoid and trapezius muscle. So mainly we need to take MMT, manual muscle test, to check this 11th cranial nerve. Next. Now last cranial nerve, that is hypoglossal nerve. Again it's a pure motor nerve. Next. Now why it is pure motor nerve? Next. Because it supply only tongue muscle. Inspect tongue, look for evidence of atrophy, fibrillation, ask the patient to protrude tongue. In case of 12th cranial nerve examination, simply we need to ask patient to protrude tongue, and then we need to check symmetry of this tongue. We need to see atrophy of tongue also. Next. See, in this picture, when we ask patient to protrude tongue, and if patient is having affection with 12th cranial nerve, then patient will have this type of atrophy, unilateral atrophy of tongue. Simply you need to ask patient to go for protrusion like this, and then you need to check any fibrillation, any weakness of muscle. And simply you can go for tongue muscle movement also, tongue movement, protrusion, extrusion, side to side deviation of tongue also, right? Next. So that was all about cranial nerve examination.